In this expert content review from the APSA Fetal Diagnosis and Treatment Committee, we will be reviewing the prenatally diagnosed double bubble sign. This review is brought to you by Stephen Papastefan, resident physician from Northwestern, Rodrigo Mon, pediatric surgeon at Emory Children's Hospital of Atlanta, and Augusto Zani at Washington University in St. Louis. Prenatal double bubble is a finding on fetal ultrasonography associated with proximal congenital obstructions of the GI tract, which occur in 1 in 2,000 pregnancies. The median gestational age at diagnosis of the double bubble is 26 weeks, but has been reported as early as 14 weeks to as late as 38 weeks, depending on the study. In one retrospective study of fetuses in whom prenatal double bubble was found, up to 20% did not have any detectable abnormality on 20-week ultrasound, and the double bubble was detected only upon repeat evaluation performed for rapidly increasing maternal fundal height, or polyhydramnios, later in the pregnancy.
The differential of prenatal double bubble includes various forms of proximal congenital GI tract obstruction. A retrospective study by Ingwell Gill et al. Found the most common etiology to be type 2 or 3 duodenal atresia at 39%, followed by duodenal webs at 32% and annular pancreas at 16%. Less common causes included proximal jejunal atresias, which have also been reported as a triple bubble on prenatal ultrasound, malrotation with volvulus with or without associated jejunal atresia, and pyloric atresia.
The hallmark finding on prenatal ultrasound is a dilated stomach with adjacent duodenal dilation. As previously noted, polyhydramnios after 24 weeks gestation is often found, but determining the specific type of proximal GI tract obstruction can be challenging. A hyperechogenic band near the duodenum can be highly suggestive of an annular pancreas, but unfortunately is rarely found. A common finding that may be referred for prenatal counseling is the finding of an isolated large stomach. Most often, this is a benign finding, with one study demonstrating 98% of cases had no associated anomaly, and therefore, reassurance should be provided for most patients with this finding.
After identification of a prenatal double bubble, formal fetal echocardiography and advanced genetic investigation should be conducted. Rates of associated cardiac and other structural anomalies have been reported to be as high as 38 to 71%, and associated genetic anomalies as high as 50 to 62%. The most common association of duodenal atresia is trisomy 21, but several other genetic anomalies have been reported. Polyhydramnios is found in as many as 69% of fetuses with prenatal double bubble, and there is a high associated rate of preterm birth in some studies, likely owing to progressive polyhydramnios.
The prenatal double bubble sign has a relatively high sensitivity for the detection of proximal GI tract obstruction, with one study at an advanced tertiary center detecting 85% of cases. The test has an extremely high specificity of 97%. Finding a prenatal double bubble with associated polyhydramnios can be considered to be pathognomonic for a proximal GI tract obstruction with a specificity of 100%. However, this finding reduces the sensitivity to 68%. It is likely that the detection of prenatal double bubble is enhanced centers with more advanced fetal ultrasonography, and that this detection has improved over time with increasing experience.
The impact of diagnosing a prenatal double bubble on patient outcomes has not been well established. Two small studies found that patients with a prenatal diagnosis underwent surgery earlier, with the latter study by Bittencourt et al. Finding an additional improvement in the time to onset of intestinal feeding and the time to complete transition to intestinal feeding. Perhaps more importantly, this finding allows pediatric surgeons to provide more informed counseling to families, giving them the opportunity to seek treatment at centers with advanced postnatal pediatric surgical care and to prepare mentally for the possibility of surgery in the neonatal period.
Thank you for your time. We hope this provided a useful review as part of the expert content review series from the APSA Field Diagnosis and Treatment Committee.